Afternoon, doctors. Today, allow me to present to you a rare case of a pulmonary sequestration in a preterm infant who underwent thoracotomy intersection of pulmonary mass. Just a disclaimer, the parents of the patient consented to photography of the operation for medical and scientific and educational purposes. Pulmonary sequestrations are abnormal ectopic non-functional pulmonary tissue with a systemic blood supply that does not communicate with the tracheobronchial tree. It develops from the ventral aspect of the primitive foregut during the embryological development of the lungs. It is a rare diagnosis with an incidence of 0.15 to 1.8%. Surgical treatment is thoracotomy. This case report was written since there is a known number of documented anesthetic management of low birth weight preterm infant undergoing thoracotomy, excision of pulmonary sequestration in the Philippines. This is a case of a preterm newborn female delivered by a primary cesarean section secondary to a non-reassuring fetal status. Patient was born to a 39-year-old G1P0 at 30 and 5/7 weeks age of gestation. In the third trimester, the ultrasound of the mother showed a solid mass measuring 3.9 by 3.8 by 3.4 centimeters in the left pleural cavity above the diaphragm with a feeding vessel coming from the thoracic aorta. Examination of the thorax showed significant amount of pleural effusion in the left. The heart and the medial sinus structures were displayed to the right. Upon delivery, the patient had an APGAR score of 99 and a birth weight of 1,790 grams. However, on the 15th minute of life, the patient was noted to have grunting and subcostal retractions. The patient was intubated using endotracheal tube size 3 at level 7.5. Patient was then admitted at the neonatal intensive care unit. Chest X-ray showed pleural effusion on the left lung field, and the patient then underwent closed tube thoracostomy. Chest tube was eventually clamped and removed. Patient was then weaned off from mechanical ventilation to high-flow nasal cannula at the 6th day of life. However, on the 16th day of life, the patient was noted to have episodes of apnea. CT scan was done, which showed massive amount of left-sided pleural effusion with compressive atelectasis of the left lung and right-sided shift of the mediastinal structures. An apparent interruption of the interventricular septum was also noted, for which a ventricular septal defect cannot be ruled out. Chest tube thoracostomy was reinserted and patient was then referred for surgery for the management. The patient was then cleared as high risk for the contemplated procedure. On the 37th day of life, the patient underwent thoracotomy, resection of extralobar pulmonary sequestration under general endotracheal anesthesia. During this time, the patient's weight was 1,920 grams. Patient was induced using fentanyl, atropine, sevoflurane, and rocuronium. Patient was intubated using Miller size 0, size 3 uncuffed endotracheal tube, secured at 8 centimeters. Anesthesia was maintained using sevoflurane. After induction, CVT and arterial line were inserted. Patient was then placed on right lateral decubitus position. Patient pressure control ventilation was used with intermittent manual assisted dual lung ventilation during the exposure of the pulmonary mass. The anesthesia time lasted for 3 hours and 38 minutes. There was minimal blood loss and the patient tolerated the procedure well. There were no episodes of hypotension and desaturation during the course of the procedure. Postoperatively, the patient was maintained on mechanical ventilation and was then transferred to the NICU. Patient was then weaned to high-flow nasal cannula. During the course of the admission, patient had good weight gain with no signs of respiratory distress. No retractions were noted. Patient remained clinically stable and was eventually discharged on the 48th day of life. Anesthesia for preterm infants presents with several challenges due to their immature physiology and incomplete organogenesis. They have an immature lung due to the decreased surfactant, which increases the risk for respiratory distress syndrome. They are also prone to apnea associated with bradycardia. This usually occurs within the first 12 hours after surgery, but may persist until 72 hours. Also, infants with low birth weight undergoing thoracic surgery was noted to have worse outcome compared to infants with normal body weight. Thus, the need for post-operative monitoring is greater. In doing thoracotomy, lung isolation provides better surgical conditions and optimal visualization of the thoracic structures. However, the smallest sizes for the single lumen and tracheal tubes and bronchial blockers are appropriate only for age 0.5 to 1. The smallest sizes for univent tubes is appropriate only for pediatric patients at age 6 and above, whereas double lumen tubes are appropriate only for ages 8 and above. In a study by Dinchman et al. In 2013, the preference of single lung ventilation was based on the following criteria: weight of more than 2,000 grams, no major cardiac anomaly, primary dependence on mechanical ventilator, cardiac medication, or pathology of the contralateral lung. The location is the upper lobe, the middle lobe, and the central lung. The type of pathology is an infection of tumor. Their data suggests that both single lung ventilation and dual lung ventilation can be performed without respiratory compromise or surgical complication when these specific criteria are applied. The patient's weight of 1,920 grams, the presence of a ventricular septal defect, and the location of the mass at the left lower lobe do not meet these criteria. Hence, dual lung ventilation was done. Manual retraction was used to obtain adequate exposure of the thoracic structures. Another anesthetic consideration in a thoracic surgery is the positioning of the patient. In a spontaneously breathing patient, ventilation and perfusion are greatest in the dependent portions of the lung. This can be attributed to the gravitational forces. However, general anesthesia, neuromuscular blockade, and mechanical ventilation result in the decreased functional residual capacities of the lungs. In infant in lateral decubitus position, the rib cage are easily compressible, thus unable to support the dependent lung. The normal dependent lung is then at risk to develop atelectasis. The high initial peak flow and decelerating inspiratory flow pattern used in ventilatory and in pressure-controlled ventilation can result in recruitment of additional lung units and improve ventilation of the alveoli, decreasing VQ mismatch. There is more laminar airflow at the end of inspiration and more even distribution of the ventilation in the lungs. Hence, the risk for atelectasis decreases. PCV also decreases the risk for volutrauma as compared with volume control. All these lead to a better oxygenation. For our conclusion, pulmonary sequestrations are a rare congenital pulmonary malformation surgically treated with thoracotomy. Anesthesia in a preterm infant undergoing thoracic surgery poses several challenges. This is due to their immature physiology, unavailability of the proper airway devices, and other associated congenital defects. Preoperative evaluation, preparation for the proper airway and monitoring equipment, and an in-depth understanding of the physiologic changes in an immature infant are necessary in the anesthetic management. In this report, intermittent manual-assisted dual lung ventilation was done successfully during the exposure and surgical excision of the mass. Currently, there's limited literature available discussing the anesthesia in preterm infants with pulmonary sequestrations, hence it is recommended to report other techniques in the management of patients undergoing this type of procedure. Thank you very much for listening.
Wow.